State Drug Trends. My name is Caleb Banta-Green. I work here at the University of Washington. I'm a research professor in the Department of Psychiatry and Behavioral Sciences, and I'm the director of our Center for Community Engaged Drug Education, Epidemiology, and Research, which I'll tell you more about in a moment. Some Zoom housekeeping. The call is being recorded. Mute when not speaking. The audio and video controls are in the lower left corner. And as was mentioned, and will probably be answered a couple of times, we will be sharing the slides with folks for sure. And I will also say almost all of these data are available on our webpage where you can get into it even more. So before I continue, I want to first acknowledge that as we gather today, we are on the ancestral homelands of the indigenous peoples who have lived on these lands since time immemorial. And I hope you'll join me in expressing our deepest respect and gratitude for our indigenous neighbors. And I think this point is particularly important, as I'll discuss later, about some of the really disproportionate impacts we're seeing around trauma and around the resulting substance use and mortality that we're seeing when it comes to drugs. So we're going to cover a lot. I'm going to scratch the surface on a lot of things. These data are all available online. I'm really just today trying to give a broad overview of what's out there and show you where to get more information so you can dig into this more. I'll also mention that as we go, I'm going to try to pause, and Allie will let me know if there are any clarifying questions along the way. So along the way, probably the first 45 minutes, if you just have if something wasn't clear, you need a little more detail on something, those questions I'll try to ask along the way where they're relevant. And then I'll save some time at the end for more questions and answers. So again, I'm going to give an overview of our center. I'm going to talk a bit about sort of why do we care about drug trends and what's available. And then get into some things around what are we seeing in specific drugs? What are we learning when we actually talk with people about their substance use via surveys and interviews? What are we seeing in terms of utilization of different types of services? What are we seeing in terms of morbidity, that is bad health outcomes, and also mortality? And we're going to talk sort of a little side piece there on xylazine, because I get a lot of questions about that, share with you some overall resources, and then have a bit of a Q&A. So first, I do want to introduce sort of our Center for Community Engaged Drug Education, Epidemiology, and Research, which is hopefully what it sounds like and fairly straightforward. We have an amazing team of people. I particularly want to point out today, in the context of the data that we're working with, Susan Kingston has been just instrumental in helping sort of build out our Syrian Service Program survey work. And Allison Newman's been working with her very closely on the qualitative work, as has Teresa Winstead. And then I also want to mention Jason Williams, who's just been instrumental with so many of the data visualizations that I'm going to be showing you. Then I also want to call out one of my students, Sam Singh, who's also been helping on the qualitative work. And you'll be hearing more in the next year or so, both around some of the research that Adam and Saul have been doing. So it's an amazing group of folks. This is truly a group effort. And I'll also mention just putting on presentations today, Allie and Kelly and other folks, and then generally our webpage. There's just a lot going on behind the scenes. There's a lot of people working on this. So a little reminder, which sometimes gets lost when we're talking about drug trends and data, but we're talking about people. I mean, that's what matters in all of this, right? And understanding that people use drugs for a lot of reasons, initially and ongoing. And said really crudely, but drugs are used to either feel good and or not feel bad. And there's a lot of both internal and external reasons that people want to feel good or not feel bad. And the understanding the context of use is really essential for prevention, treatment, harm reduction. And we need to understand those things. So these data should not be looked at in isolation. They don't mean anything in isolation. And in that same way, simply removing substances does not solve substance use or substance use disorder. The context and meaning of the substances in people's lives, the value they provide, both good and bad, is essential to understand. So we'll try to touch on that a bit as well. So, in thinking about the data side of this, we need to remember that substance use is often very much a hidden phenomenon in many ways, and therefore it's often quite difficult to accurately quantify what's going on. That's because both drugs and the people who use drugs are highly stigmatized and criminalized. General population surveys around drug use are extremely problematic. There's a lot of social desirability bias. The folks who most want to respond to surveys are the least likely to respond. And in general, population surveys have gotten more difficult as people's modes of communication have changed. So instead, we really rely on multiple data sources to understand what is happening with both drugs and drug use. Each of these data sources has those problems. It's got its biases and its limitations, and we need to be mindful of that. Different data sources show different things. You might be looking at two different data sources on the exact same topic and the same folks, and are showing the opposite findings, and they can both be correct. Understanding that is really important and a really important dynamic. Taken together, sort of the careful consideration of these data sources, the data, and our understanding of substances, the actual drugs themselves, substance use, use disorder, and those health packs really can yield reliable and valid findings. I'm just past my 22-year anniversary doing drug epidemiology in Washington State. And before that was very fortunate to have both clinical and research experience where I got to sit down and talk with human beings. And I'm so glad that I was initially grounded in that, in the person's experience of their life and the role that substances play to help interpret what these data are and to bring on new data sources that hopefully are more meaningful. So I'm going to just start with one of those data sources, our newest one, which is the Community Drug Checking Network data. These are drugs that are tested at harm reduction agencies in Washington State. This is a new project. It's been around for about a year. The data I'm showing here are results from gas chromatography and mass spectrometry. That is the very detailed chemical analysis. And these are data for a little over a year. So these are over 1,100 drug samples that were tested. An important bias to consider is what drugs are people going to get tested? Drugs they're worried about, right? So things that they've either had a bad experience on, highly likely they're going to be non-illicit substances. You're unlikely to bring in your pharmaceutical product you got at a pharmacy for drug testing. There's no reason to do that. And so that's important context. And so what you see here are the most common drugs that we've identified. Methamphetamine and fentanyl, both about a third. Those are by far the most common substances that we're seeing, followed by cocaine, ketamine and related substances, heroin, and non-prescription benzodiazepines. Sorry for that kind of those acronyms and short jargon down there. That's non-pharmaceutical benzodiazepines. And benzodiazepines are things like Valium and Xanax. And then on the non-pharmaceutical side, we're looking at compounds like bromozolam and atizolane. So again, as is always the case, there's generally a stimulant and a depressant that dominate the market. And right now it's methamphetamine and fentanyl. When I did my training long ago, it was cocaine and heroin. And as people are probably pretty familiar, those things ebb and flow over time. I am generally going to try to post at the bottom of each web page, each of these slides, what the data source is that I'm working from. So let me break down this one a little bit. This takes a bit of interpretation, and this is also on our web page. And this is looking at what the drug was sold as versus what it actually was. And this is for 4 different compounds, and I'm going to describe them a bit. So in the upper left here, these are substances that were sold as, we're calling them fentanyl pills. What we really generally mean is something labeled, tableted as an M30, with generally a blue or greenish color, although other colors are out there as well. So essentially fentanyl pills. And we're looking at the most current data we have. So we're looking at over the last 3 months, October, September, and August. Over that period of time with the community-based drug checking, tested 48 samples that were sold as fentanyl. That's sort of this outer color scheme here. 48 of these were sold as fentanyl. Blue, 47 of them were fentanyl. 47 were fentanyl. And then what we're doing for each of these compounds is examining an additional drug of interest that we know from working with our community drug checking network partners, our harm reduction partners in the community. What is the relevant other thing that people should and or want to know about? What's important to understand in these fentanyl pills is they almost always have acetaminophen in them, what we label as an other analgesic. But this green area here is showing that almost all of these compounds also have acetaminophen. And that's actually relevant because people are often using dozens of these tablets, and there's often a lot of acetaminophen in there, which can actually cause liver damage. And then lastly here, this orange here is showing xylazine, an animal tranquilizer that you've probably heard a lot about on the East Coast, and I'll talk more about as we continue here. So the way to look at this overall, just to recap, these are things that were sold as fentanyl pills. There were 48 of them that were sold as fentanyl. 47 actually had fentanyl. An important compound that we see oftentimes is acetaminophen, and we occasionally see xylazine. So now looking at things that were sold as fentanyl powder, we had 43 samples that were powders that were sold as fentanyl. 36 actually contained fentanyl, And in this instance, 6 contain xylazine. And these data are online. You can go play with them. I'm just showing you what we've got here. Looking in the lower left, we had 17 samples sold as cocaine, 16 actually had cocaine, 3 had fentanyl detected, and 1 had lobamycol detected. I want to pause there for a moment because what we don't know is, were these sold as a substances that was combined? Did somebody sell it as something that was cocaine and fentanyl? Did a person purposely combine that? Or perhaps they might also have inadvertently just shared a container or shared a baggie. So the drugs weren't actually combined. It was the container they were in. And we can't tell that definitively. The GCMS, or the gas chromatography and mass spec that we use, is incredibly sensitive. So that's important to know. And we did see an instance of lobamycol, which has been a contaminant that's been around in cocaine for a long time. That is now, I'm actually surprised it's not more common than that. It used to be more common than that. And then just to wrap this up, and please let me know in a moment if you have any immediate clarifying questions. This is looking at methamphetamine. There were 89 samples sold as meth, 86 had meth, 4 had fentanyl, 0 had xylazine. So it's a concern that we get. And there can be some challenges and questions that come up that I won't get into today, where there can be false positives on some of the test strips that lead people to be confused. And so that's why we have the additional information for the community drug checking can add some clarity where test strips might sometimes add some confusion. Is there any immediate question on all of this, Ali? I know these are complicated data.
Nope, good to keep going.
Okay, great. And just as I said, we are, and we'll have the link at the end here. We are having a whole webinar next week around drug checking, which I encourage you to check out. Mention that. And I also encourage you to take a look at the webpage. We have multiple layers of data. This is just the data on the first page. We actually have 2 more layers of data where you can really dig into what's going on.
There was a question about if the sold descriptor is self-reported by the client.
Yes. Yep. So very important question. So I'll briefly say within drug checking, people are generally bringing in drugs. They're bringing in drugs to be tested. And what they're getting on site is they're generally going to get test strips are going to be used on site. Generally, fentanyl, xylazine, and benzodiazepine test strips will be used. A machine called a spectrometer will give an additional level of chemical analysis. That will all be done on the same day. Those results will be given back. They're never definitive results. We never say these substances are safe. We can't say that. We also know the results are not definitive. These GCMS results are incredibly helpful, and those generally come back a week or 2 later. They give additional detail. We give a QR code for folks so they can get those results online, or they can come back in and get those results. So that's super important. But to the question that was asked, we also asked people, what was it sold as? Did you use it? What did it feel like? Did anybody have a bad outcome on it? So we're asking those other contextual variables as well. And this is brand new. This webpage has just gone up in the last couple of weeks. This is a big project, and we'll be continuing to grow and layer on both added harm reduction services, real value, first and foremost, for people who use drugs to make informed decisions, and have conversations within a community about what's in their substances. And then also to do some of these types of analyses, more epidemiological analyses, to understand what's going on with drug trends. So another way to look at this is sort of a one-off thing. This happened earlier this year, where the Seattle King County medical examiner sent in a few samples to the DEA to do some very detailed analysis. The analyses that we're able to get back are what are called qualitative results. It's which substances are present. This DEA special testing lab is able to say which substances are present in the amount. So I just want to show you this just as examples. I'm not saying these are representative. We don't know whether they are or not. As an example, this is what a fentanyl pill or an M30 typically looks like. And what we found in this particular product, the whole thing weighed about 108 milligrams. 40 milligrams of that was acetaminophen. About 1.5 milligrams was fentanyl. And then we see these precursor compounds that are really just indicators of the fentanyl, how it was manufactured. So the takeaway from this is that in about 100 milligram tablet, about 40% of it is acetaminophen and about 2% of it is fentanyl. I will say, because you will hear this a lot, you'll hear, oh, that's a lethal dose of fentanyl. That might be a lethal dose of fentanyl for somebody who is naive, who has never used opioids or does not have any opioid tolerance. But for a person who uses fentanyl regularly, that may be barely felt. a person may be using hundreds of milligrams a day of fentanyl potentially. So when you hear that about, oh, we seized this much amount of drug, it would kill these many people, I encourage you to understand the really important thing is that isn't designed to kill that number of people. It's actually designed to keep a much smaller number and proportion of people to prevent them from going into withdrawal. That's important to understand because it tells you how much people are using, how much opioid tolerance they have, and then that has profound implications for the so what does that mean for drug treatment? It means we need to make treatment available and we need to make sure people are getting an appropriate amount of medication. So this is just showing what we see in just a single pill. And this is an example of a single powder. This was 300 milligrams of powder. And the real takeaways here are a couple things. One, there's 13 milligrams of fentanyl here. In this instance, that was about 4% of the product. We've seen other powders that might have 20% or more, so a lot of variability. There's also methamphetamine in here. There's also atizolam, which is one of these non-pharmaceutical benzodiazepines. There's some cocaine. So this is just, to me, it's pretty stunning to see this huge number of substances that are present in this compound. So this is very different than when we were looking at botanical products, cannabis, heroin, cocaine, sort of in the old days. This is what we're seeing. You'll see this in these data today, are a huge array of compounds, and many of them newer compounds that we're still figuring out what they do and how potent they are, and also how to care for people who use them.
Dr. Jasmine asked that if the primary drug isn't found, I'm assuming this is in drug checking, what is it then? Typically just filler?
It depends, and I encourage you to look at the data that we have online. You can just really dig in and see that. So it might be a different compound. It might have been sold as methamphetamine and it's actually fentanyl, or MDMA and it's actually methamphetamine. So it might be a different drug or it might be a filler. But what we're generally seeing are that there is some other parent drug present. And again, on the webpage, we really dig into that in detail so you can see what those substances are.
And Miles asked if mostly the people that bringing in substances clients.
It really varies. So some of them may be long-standing harm reduction clients. Some of them may be treatment or healthcare clients on site. Some new folks may come in who wouldn't otherwise. It's really a big mix of people that we're seeing. And next week will actually be a really good chance to dig into that as well. But Ben Beaumont, who works with us, will be leading that call, and we'll have a couple of our drug checking programs on there they're the perfect folks to really dig into those questions. So another data source that we look at in terms of what's in the drugs are the Washington State Crime Lab data. And they're complicated, and they're complicated for a lot of reasons. Again, these data you might think are biased towards drugs that law enforcement are likely to come into contact with, which are probably substances that are more likely being sold, quote, on the street than things that people might be buying off the internet. They also might be based on what are the priorities in different communities across the state. Those things can change, what the emphasis patrols might be looking at. And so those are just important considerations when thinking about crime lab data. These are also cases then that generally when they're getting sent to the crime lab by local law enforcement that they're looking at prosecuting. So there's some other contextual things going on that it's a case that's going to get prosecuted. We then have over here in this gray region, just to share with you, the Blake decision, which was now almost 3 years ago, which changed the classification of most controlled substances and from being essentially a felony to misdemeanor. There's been multiple things that have happened that I'll show more about in just a moment. But what we saw before this really radical policy change here was that methamphetamine was the predominant substance. Heroin was the second most common substance. And then you see down here, this light blue line, this is other opioids. Well, back here, other opioids were pharmaceutical products like oxycodone, hydrocodone, OxyContin, Vicodin. And then more recently, we're looking at illicit fentanyl. And so that's actually what we're seeing. And during this period of dramatic suppression of these cases overall, we actually saw a continuing increase in fentanyl, which I'll go into detail in just a moment. This dark green line here, these circles, this is cannabis products, THC products declining dramatically. And cocaine generally declined dramatically as well through 2022. I'll show a little bit more about that. So this is now looking at, these are slightly more current data. So we've put quarterly data up that are more preliminary. This is this Blake decision era. And then this new era that was There was the Blake decision, which is a state Supreme Court case. There was a legislative response, Senate Bill 5476, and then another legislative response, Senate Bill 5536, that made drugs again we went from a felony to a misdemeanor to now we're back to a gross misdemeanor, and we're starting to see arrests and prosecutions increase. That's what this little pink component is over here. The substances we're looking at here, though, are just fentanyl in green and fentanyl analogs. These are things that are fentanyl-like, sometimes weaker, oftentimes stronger. What's important to see here is that even as there was this dramatic decrease in these cases, generally fentanyl increased. The other takeaway is the distance between these lines. That when we're looking at fentanyl-type compounds, at least here in Washington State, we are predominantly looking at fentanyl itself, not things like sufentanil, carfentanil, acetylfentanyl, all these other fentanyl products. It looks like we saw them for a little while in 2002, and we're seeing them less so. That's the type of thing we'll be continuing to track. This is looking at benzodiazepines, and again in black, this is all benzodiazepines. Back in the day, those are going to be things like Xanax and Valium in terms of brand names. And then non-pharmaceutical benzodiazepines started to show up 2018. They began to increase. Around here, at least in law enforcement evidence, we were seeing very similar numbers. And what we're seeing, and I'm not showing the data today, is in the drug checking data, we're generally, if we see something that looks like a pharmaceutical benzodiazepine that a person brings in, that they bought off the street, it is almost always one of these non-prescription benzodiazepines like bromazolam or atizolam. And we see some complementary data out of some detailed drug testing that some opioid treatment programs are doing as well. So benzodiazepines are a super important other drug class to be aware of that's out there. People use them on their own right, but very oftentimes to add to the impact of other substances, often opioids. Any follow-up questions on sort of those drug slides, Data Alley?
Not right now.
Okay, so switching tunes entirely, going from chemical analysis of drugs, and we're now going to go the opposite way and talk just very briefly about these qualitative interviews that we've been doing. And these are really exciting data and information. I strongly encourage you to take a look at these reports, but also I think we've recorded most of the presentations that were given by the authors of these. These are all available online. I'll show you where in a little bit. So I'm going to just briefly talk about some recent work done earlier this year around fentanyl and some data that's a couple of years old, but is still very relevant around methamphetamine. So just to share with you, in terms of looking at the perspectives of people who use fentanyl in Washington State, these were exactly 30 people who were syringe service program clients who reported recent fentanyl use. I do want to say that even though we use the term here syringe services programs, I think we're really talking about harm reduction programs. I'm not indicating that these people unnecessarily were using syringes, whether they were injecting. A lot of people are smoking fentanyl as well. Some of the main findings is people have really complex reasons for using fentanyl, including pain, mental health, withdrawal because they were dependent, and just the sheer availability of fentanyl and the lack of availability of heroin. Most participants were interested in stopping or reducing their fentanyl use, but saw significant barriers to doing so. Either they had concerns about the medications that are out there, which are the most effective treatments, or they couldn't get them, or they were on those medications, but their provider was discharging them because they continued to use fentanyl, even though they were on those medications. And just to be clear, those medications still provide a lot of benefit to people, even if they continue to use. So we asked them, what does ideal care look like? Accessible, really easy to get. We'll talk more about what that looks like. Non-judgmental, and holistic, really comprehensive. The non-judgmental thing, I just can't say enough about that. I think another way to think about non-judgmental is that from the participant's perspective, and hopefully the care provider's perspective as well. Too often, these interactions are antagonistic. They are combative. People are working at cross purposes. But when we can bring in a harm reduction framework and a person-centered approach to our work, we can actually have a collaborative approach to the work that benefits the client because they actually are going to get the services they need and they want to come back. And it benefits the provider because it's just a better relationship. It's a nicer interaction to have. So really trying to think about how we take all of these data that we have and think about this so what in terms of how do we set people and provider up for success. And then many participants lack stable housing, employment, transportation, childcare, and primary health care. And the program should work to address these needs. So to that point I made earlier, just removing the drug doesn't fix what's going on. We need to look at all of those things that are intertwined with substance use. And again, we have the detailed report online, we have the webinar online. I strongly encourage you to take a look at it. It's wonderful. And then a bit around methamphetamine. This was 27 folks who were syringe service programs in Eastern Washington use methamphetamine. I'll just share with you based on my experience and other data. There's no reason to think these results are any different or would not apply in Western Washington. I think they would. Really importantly, most participants saw both benefit and harm for their methamphetamine use. They had interest in stopping or reducing their methamphetamine use, but it was kind of fluid. It wasn't like, yeah, I definitely want to stop. I want to do it today. It's like, well, I'd like to stop, but I don't know when, or maybe I don't really want to stop. And then again, just like with folks using fentanyl, many people lack stable housing, employment, transportation, childcare, and primary health care. And to share with you overall, we generally see for folks using heroin or fentanyl that is strong majority, 75 or 80% will say they do want to stop or reduce their use. So a strong majority. When it comes to methamphetamine, it's more like maybe half. And so there's important lessons learned from that in many different ways. One is that if the only service you're offering is a goal of getting that person to stop using, you're leaving out a bunch of people. There's a lot of other folks who may not want to or be ready to stop their use, who still deserve care and interaction and support. So there's those aspects. And then there's also understanding the role of the drug in people's lives, particularly for folks who are unhoused. The reasons that methamphetamine is a Schedule II pharmaceutical drug, and its analogous drugs are used in many instances, amphetamines, to support people in higher functioning. Those same functional benefits help people who may have mental health issues, who are unhoused, who are vulnerable at night to predation. There's a lot of important reasons that people use, and understanding those reasons are really going to be key to having effective service utilization for folks. So a little bit about harm reduction services and supplies. I'm not going to share with you quantifiable data. We don't have as much quantifiable data. We have some, but I'm not going to show it today. What I will say is that, we historically have had a lot of syringes distributed in Washington State, well over 15 million a year, like large amounts of syringes were being distributed through syringe services programs. Those numbers have really declined pretty meaningfully just in the last handful of years. And a lot of that is because people are switching to smoking, and or there are newer folks coming into use who are smoking, particularly fentanyl and methamphetamine. So we're beginning to see more smoking supplies. Both more sites have smoking supplies and people are using them increasingly often. So we're seeing that shift. Naloxone, which has been around for a long time in Washington State, and a long time. Distribution continues. What we're also seeing is people are coming back really frequently. Overdoses are happening more often, and they're administering naloxone more often. So they're needing to come back for more kits many more times over the course of the year. Fentanyl and other drug test strips are increasingly being distributed. And as I just mentioned, the community drug checking network, the client numbers are increasing, and we're adding a few more sites coming up really soon.
There are a couple questions.
Oh, sure, please.
So are there any work or behavior changes once product contaminants are known? For example, someone purchases a product they tested positive for fentanyl, then a decision must be made, use it or discard it?
Yeah. So again, I'm going to give you a quick answer, and I really encourage that conversation next week. Generally, if a person is dependent on opioids and they have an opioid and it's tested positive an opioid, they're highly likely to still use it, because otherwise they'll throw their money away or go into withdrawal. What they may well do is use in a safer way. They may use less, they may make sure they're with another person, they may ensure they have naloxone. So the goal isn't to like radically change people's behaviors in the immediate term. That just isn't what happens. The goal is around engagement and helping them make safer choices in that moment and create those relationships that may lead to other change down the line.
And then somebody asked, Are there theories behind why people who use methamphetamines have a lower percentage than fentanyl if strongly wanting to stop?
Um, there are, and I'm not going to get into it. I would definitely look at the information brief. We talk a lot about that, a lot of the reasons that people use and the services they would need to address those motivators for use. I will also note that the treatments we have for methamphetamine, the most effective one is contingency management, which is generally an add-on to other programs. And that is a longer term, moderately impactful intervention, as opposed to for opioid use disorder. We have much stronger, more impactful interventions, more effective interventions with the treatment medications, buprenorphine and methadone. So there's just different dynamics going on, both in terms of motivations to use and also knowing what sort of treatments are out there.
And then can you please repeat the names of the non-prescription benzodiazepines that were found rising in 2023?
Yeah, the ones that we're seeing most often are bromazolam and atizolam. And we'll have more on the webpage about that.
Okay, thank you.
Yep. So I'm going to keep going a bit here. I'm going to share a little bit of data around substance use disorder treatment. I'm going to focus on opioids because those are the data I can generally get at the state level. We've had a big change in our drug treatment system data, and they're not as readily available as they used to be. Let me explain these data because they're funky. That's a technical term. They're funky. So these are data from opioid treatment programs. Historically, we often thought of this as, quote, methadone clinics. Many of them are also using buprenorphine as well. These are data from just a very sort of snapshot registry that the state that the state does on a regular basis. This is Lighthouse Central Registry, and it's just a description of how many people are on care on a current day and what is their primary drug. So it's a very crude measure. It's very slow to change because it's prevalent. That means people generally stay on opioid treatment programs for many months and hopefully many years. And so you don't see change as quickly in terms of the substances, because that would primarily because you've got new people coming into the program. But the findings we see here reflect what we're also seeing in other research data and in provider reports. This is just over a fairly short period of time. From February to October of this year, there were about 14,000 active clients on each of these 2 days that they did this snapshot. And what you see here is a pretty substantial increase in fentanyl over a relatively short period of time. A modest decline in heroin, and then these other compounds. And this is not a really formal database, but I think that the fact that we saw such a rapid change in fentanyl on this scale, almost a doubling from 2 to almost 4,000 people reporting as a primary drug over a relatively short period of time is quite striking. And it's something that we've seen in other programs as well, and certainly hear from certain service program clients. We certainly see it in those data as well as the treatment providers. This is just a very crude measure, but really just kind of squint at this. This is the amount of buprenorphine. This is DEA data. This is what's sold to hospitals and pharmacies in Washington state. So this is the supply side of buprenorphine in Washington state. And you can see an enormous increase in terms of these are the total daily doses. Weird metric, I apologize, but very crudely to share with you, with about 20 million daily doses. This is based on an 8 milligram average dose, which is actually low, and 365 days in a year. One way to look at these 20 million daily doses is around a capacity for about 7,000 people in terms of an annual treatment slot. I know that's complicated, I apologize, but I think the big thing to understand, the takeaway here, is that buprenorphine utilization has increased dramatically. There's still plenty of room for additional growth. We still have a majority treatment gap, even within our Medicaid system. Among those who have documented opioid use disorder, over 60% are not on effective treatment. So there's room for this to grow quite a bit more. Another data source I'll mention here just briefly, these are Washington State drug hospitalization data. This top green line are opioids other than heroin. So essentially back in the day here, I mean, 10 years ago, we were predominantly looking at pharmaceutical opioids. You can see those pharmaceutical opioids declining. And what this really represents is this underlying increase in illicit fentanyl. So that's that sort of pattern we're seeing there. The orange line, stimulants besides cocaine, which is essentially methamphetamine, has actually been fairly steady in hospitalizations, which is interesting because the mortality has increased dramatically. That suggests that there's something around the lethality, that there's just a very high lethality of what we're seeing with methamphetamine. And there's been some interesting data out that we're not just looking at sort of what we think of as poisonings or overdoses with methamphetamine, but also some really significant cardiac effects that may be what is directly killing people, not the amount of the drug that day. And then this light purple, I'm going to go with lilac. A line that's been declining pretty dramatically is heroin. That is a dramatic and steady decline in heroin in those hospitalization rates. And then this light yellow line is cocaine, which is actually held fairly steady. So that's just one other way to look at what's going on. Okay, I'm going to spend a bit of time looking at the mortality data. I look at them in a lot of detail because they are the thing we're trying to avoid, right? That's the thing you can't go back from. They also are essentially the total population. So some of these biases we talk about, there are still some biases in which things get reported as a drug overdose, but not the same sort of undercounts or distorted counts that we see with other data sources. So the mortality data are very important to really dig into. And then we can also try to learn from those about how do we prevent those deaths. So what I'm looking at here, and these are Department of Health, Washington State Department of Health data, Conrad Otterness and other folks that have put these together. So I really appreciate them sharing these data. The gray lines are the United States. The blue lines are Washington State. The dotted line is fentanyl. So let me break this one down a bit. So this, what you can see is that we are now in 2022, we're at the same rate in Washington State, a little bit higher than where the US was a little bit before. And what I would take away from this is the separation between these lines. This light gray line is the United States. This blue line is fentanyl. That separation represents the time lag. So essentially, we have about a 3-year lag with what we're seeing in Washington State. We began to see this increase here in the United States back here on average, and it came here a bit later in Washington State. You may have heard about overall overdose deaths actually leveling off or even decreasing at the national level, and that's true, but in the Western United States, including Washington, they continue to increase. And then these data down here are for heroin, and what you can see here is that these lines actually line up very, very, very well. There's not much separation between them, and the rates are generally pretty similar. So you see this decline in heroin-involved overdose deaths, both in the United States as well as in Washington State. This is looking at stimulants. These top lines are on methamphetamine. And what the takeaway here really is that you can see the difference. Here, the separation is vertical. That vertical separation means we have a higher rate. So historically, we had a much higher rate here in Washington State. Look at 2015. We had probably double or triple the rate of methamphetamine-involved overdoses back in 2015. And we continue to see a higher rate, even as the rate is beginning to increase across the United States. For cocaine, a bit of a different pattern. We generally have had a slightly lower rate in Washington State. And in fact, even as our rate has increased, we still have a much lower rate than we see overall in the US. And that, very crudely speaking, is generally higher cocaine utilization rates on the East Coast and generally higher methamphetamine use rates on the West Coast. So digging into these a bit more, I just look at this slide. So this is right about when I came into doing this work, and this is overdose deaths. This is the raw count. So the rate is a little bit more suppressed, but still dramatically increased. So we're looking at a count of about 800 deaths. Then we really hit about 1,000 deaths a year, and we held steady for a decade. Even as pharmaceutical opioids came and went, and cocaine and methamphetamine switched places and went back and forth, on and on and on. You can begin to see what's happening here with this increase in 2014, 15, 16, and we would have been stunned just at that increase. And then this acceleration over the last 3 or 4 years is really devastating. I mean, just this crude number of overdose deaths or drug poisonings is stunning. The scale is unprecedented. So what's going on within that? What we're looking at essentially is this. Here's the same line. This is now in a rate as opposed to the crude number, but you can still see this huge increase in rate. All drug poisonings or overdose deaths in black has increased dramatically. Red is opioids. We'll unpack that in a moment. dark blue is methamphetamine, and light blue is cocaine. You can see all of these are contributing, but though in different ways. I do want to take a moment and just pause and talk about what we see for race and ethnicity in terms of just the last 4 years in terms of this overdose death rates. And you can see very high rates among American Indian and Alaska Natives. Huge rate, absolutely, and a huge increase. Similarly, a lower rate, but stunningly bad, and a large increase among Black non-Hispanics. You can see whites, which is the rough majority of our population, also nearly doubling. But again, a lower rate and a lower rate of increase. And then you can see really increases across the board, as well as among Hispanic and multiracial folks as well. But what is truly stunning is what we're seeing among American Indian, Alaska Natives, and Black non-Hispanic folks. And a lot of that is around fentanyl. And we're also hearing about it more both among African-American populations and African immigrant populations, as well as Latinx populations, Latin populations. So seeing it across the board, but really disproportionately high rates and increases among these folks. Just letting you know this exists. This is something to go dig into around some of the drug combinations. This is just an example of the type of analysis we have online. This is looking at drug pairs. People often have multiple substances on board, 3, 4, 5, 6, 7. This is just looking at the most common two-way drug pairs in overdose deaths in Washington State. When you are looking at this live online, if you hover over these, the numbers will pop up. I will read them for you. So the most common combination we saw was methamphetamine and fentanyl. So that was 26% of deaths over the last couple of years had that combination. The next most common is actually in this lower left corner. This is fentanyl only. Fentanyl only. So we're seeing that here, where that was 16% of folks. And then up here, 10% of people had fentanyl and alcohol. So just letting you know, there's additional level of analyses, depending what your interests are, what would be helpful to you, that are available online.
There's another question. Could increased counts or rates also be due to the standardization of reporting or more emphasis on reporting given national attention?
I don't think that's as big an issue here in Washington State. We've been working really hard with coroners and medical examiners. My colleague Jennifer Sable a decade ago really did a lot of outreach to them 10, 15 years ago. So I think that the data over the last 10 plus years for sure, I would think they're relatively comparable. So my short answer is no. That was my medium answer I just gave you. Any other things immediately, Allie?
Nope.
All right, thank you. So just giving you just a really broad sense geographically, just to give you a sense of scale. This is looking 2 decades ago and the most recent few years of data that we have. On the left side, the annual overdose death rate over that early period was about 5.7 or about 6 per 100,000, and we're now at 21. And the point here is, yeah, we have higher rates, in the southwest region of Washington State, but the rates have increased dramatically in every region of the state. And to share with you as well, if you want to go online, we also have these data broken down by county if you want to see those data. So that's looking at all opioids combined. Digging into this a little bit, also, this is another way to look at those drug combinations. These are opioid deaths overall, and I'll unpack this a bit more. This red shading down here, this is opioids without methamphetamine, cocaine, alcohol, benzodiazepines, or barbiturates. You can see that was quite steady for a long period of time, and a meaningful increase over the last couple of years. The proportion that were opioids plus these sedative drugs, alcohol, benzos, or barbiturates, in green is relatively steady. And then we see a very large increase in methamphetamine and opioids. So that's that is really the largest increase that we see, to the point that it's now the most common combination that we see is methamphetamine and opioids. And then you can see also we continue to see cocaine and opioids, as well as opioids and stimulants mixed together. So that's one way to look at these data. This is unpacking a little bit more within the specific opioids. Red is all opioid-involved deaths. Light blue is other synthetic opioids, which is, by our last count, Jason pulled these data just a couple weeks ago, pulled a random 100 cases that were listed as other synthetic opioids. I believe 98 of them, of the 100, were fentanyl. There are some other compounds like tramadol that come up as well, but other synthetic opioids is essentially fentanyl. So we see a dramatic increase in fentanyl. You see commonly prescribed opioids, which are basically, a bit of a decline there. Heroin had actually been coming up, and we've seen a decline just the last couple of years in heroin-involved deaths. So that's the high level there. This is looking by age, and we have a lot of age-based analyses, and there's a lot more analyses online. But essentially, the purple is looking at fentanyl. The dotted line is fentanyl for those who are 30 and older. So you can see this really dramatic increase in the rate for fentanyl-involved overdose deaths for those who are 30 or older. But we also see a dramatic increase for those who are under 30 as well, to the point that we see more fentanyl-involved overdose deaths in terms of the rate for those under 30 than we see for older heroin users. That's just something that was unprecedented back here. You can see this triangle back here is showing people who use heroin who are 30 or older, and that was really dominated what we saw. So we're seeing in orange, now we're focusing on that, we're seeing a decline in deaths involving heroin for those who are 30 and older, and a real dropping off of that for those who are under 30. So you're seeing the overall patterns around heroin and fentanyl we've been talking about, and then we're seeing how they break down for those who are over and under 30 as well. So there's some important distinctions there, and also important ramifications for making sure we're providing appropriate access to harm reduction and treatment services for younger people as well. So now I'm switching topics here a little bit, and I will wrap up here in a couple minutes and get to some more questions and discussion. This is now focused on methamphetamine. So these are deaths that involve methamphetamine. The most common we see, as we saw earlier, is opioids and methamphetamine, which has increased dramatically. And then the next most common we're really looking here is this is methamphetamine by itself. The coloring can be a little hard to see, but a substantial minority involved methamphetamine without cocaine or opioids or alcohol, benzodiazepines or barbiturates. So while the majority is opioids and methamphetamine, really fentanyl and methamphetamine, we also see a lot of deaths that involve methamphetamine by itself. And that's really important. When I came into this job 22 years ago, I was essentially told you could not die from methamphetamine. And that was also the belief among folks who use methamphetamine. You couldn't die or overdose from methamphetamine. And what we're seeing now is you can. And I think a lot of it has to do with not a change in methamphetamine. My understanding and talking with pharmacologists and others is that even as production has changed around methamphetamine, that isn't what's driving these deaths. What's really driving these deaths is the sheer availability of methamphetamine, the social circumstances of use, and also the chronic impacts around the cardiac effects of methamphetamine really catching up with folks. So that's a bit on methamphetamine, and then showing you as well this dramatic change in the overall. As I said, back when I came into this work, we saw very few methamphetamine involved overdose deaths, 1.5 per 100,000, increasing to 16.7. Huge increases. Yes, also concentrated in Southwest Washington, or higher rates, I should say, but very high rates across the state and increases across these time periods everywhere. Want to pause a little bit on xylazine. What we've seen in terms of overdose deaths across the state the last couple of years, less than 1% of fentanyl-involved overdose deaths also had a xylazine present. The medical examiner data in King County that are more current show a similar very low proportion. Police evidence testing in the first half of this year, about 1% also tested positive for xylazine. So there was fentanyl, only about 1% of the time was there also xylazine. There is some underreporting in crime lab data because xylazine is not a controlled substance. So that is a bit of an underestimate in the police evidence, but it definitely is a low proportion. And then Vancouver, Washington, Dr. Kevin Fisher down there has been very kind in sharing their enhanced drug testing they're doing down there. A little bit complicated, sort of which group we're talking about, but I think what we're seeing consistently is that there's still a small proportion, less than 10%, but more than the 1% we see in other places, of people who are in our opioid treatment program who test positive for fentanyl. They're also seeing xylazine in those samples. So, and not really seeing changes. So the thing within all of these data sources is that it's a low proportion. It stayed relatively steady the last couple of years, has not changed. What I will say in the drug checking network is that we've seen about 5% of the fentanyl testing positive for xylazine, and we occasionally see increased pockets of that. We might have 3 samples in a week that test positive for xylazine. So we're really keeping a really close eye on that. And the nice thing is, as you see those data, we're updating them on a monthly basis. So we certainly will let folks know if we see a change in xylazine in the drug market. So a couple last things, methamphetamine and fentanyl availability, use, and harmful impacts are up substantially. The reasons for using these drugs have also increased, whether it's social anxiety, social isolation, whether it is trauma, financial trauma, emotional trauma, cultural trauma. All of those things are persisting and were really exacerbated in the context of COVID as well. And now you have these synthetic drugs like methamphetamine and fentanyl that are incredibly cheap and incredibly available. Our care models are beginning to be more accessible and engaging to better address the reasons people use and the impacts of use. We're trying to expand the time and the hours that they're open, the models of care, more drop-in, trying to add other really value-added services like wound care and behavioral health, trying to expand our staff and volunteers, have more folks with lived experience who are engaged in the process, who are providing services and can help with care navigation. Our drug use trends measures are getting richer. Drug checking data are really important, like qualitative work, but we have important gaps persisting. Smaller communities often don't have these services or these data. The treatment and harm reduction service utilization, we'd like to get richer data on that. We're working to build that out. I do want to just let you know, please take a look at our webpage. The shorthand for our webpage is adai.uw.edu. Within that, we have our CDER webpage. Maybe Ali, if you could post those links in the chat, that'd be helpful so people can just click those and bookmark them. So we have a lot of different data, by geography, by drug type, by indicator data source. This is my teaser graph. This is a Venn diagram that Jason put together. This is just an example of what are the drugs that are present in an instance where people have fentanyl. And then we break this down further by what does it look like for fentanyl versus heroin? What does it look like among fentanyl for those who are over and under 30? So there's a lot we can dig into. There's important implications for harm reduction and treatment services. We have a lot online. We stopoverdose.org, learnaboutTreatment.org. We have a beautiful tribal sovereignty series that Lisa Ray Thomas facilitated and put together this last summer that's available online. We have these data, and then we have some of these data sources also, our surveys, and some of our other different gatherings that we put together. So I encourage people to take a look at that. We do have a webinar that's specifically focused on drug checking. I know it's a new thing. I think people are pretty interested in it. I know I'm really interested in it. I encourage you to come take a look and listen in and contribute and ask your questions around drug checking at that upcoming training. So with that, we have a few minutes left. I would love to take any questions that folks might have. If you want to start with putting it in the chat, let's start with that. And if we need to, we can bring folks on to ask them directly if needed. That all makes sense. Any things I've not addressed yet in the chat, Ali?
Nope, I think we got through all of them.
Okay. Well,
Oh, a new one just got added from Laura Jasmine. What do we know about the illicit ketamine supply and ketamine users? Are they specifically asking for it, or is it included?
Thank you, Dr. Jasmine. What we're hearing at the Drug Checking Network sites is that it generally are people who are seeking out ketamine, people who are trying to use ketamine and are concerned about what may be in it, whether it is ketamine or if there are other adulterants in it. So at least in the Drug Checking Network site, it's people who are purposely trying to use ketamine.
And then does the increased rates of death from fentanyl for those over 30, while the decreased rates of heroin death for the same group speak to the potency, increased use of fentanyl, or both?
Yeah, so I mean, I think with fentanyl, what we really saw was that there was this dramatic increase in availability of fentanyl. It was extremely potent. It was extremely cheap. there is something about those M30 tablets where there was a while where people might have thought they maybe were getting a pharmaceutical product, but I think there still is this aura of safety somehow. I'd have to ask my psychologist and psychiatrist friends on this call. I don't really understand it, but there's been this persistent aura of safety around those pills. So I think that they were somehow seen as safer, even when we knew they weren't. So it really was around this. I mean, it was a market thing, right? It was a market thing. It comes down to profit, right? The folks who are manufacturing, distributing these drugs and selling them, there's a lot more profit to be made with fentanyl than there is with heroin for many reasons. So it really was around availability. And then for new people into use, the incredibly fast acting onset of fentanyl and its short duration is just a really strong addiction potentiator for folks, and also a really extreme overdose risk. So a couple of those things I think are factors.
What drugs are used to help detox a fentanyl addiction?
Oh, okay. Thank you. So assuming that is the person means fentanyl. So detox is a great question. So when it comes to people who are dependent on opioids, the most effective thing to do, the most effective treatment by far, which has dozens of articles out there, if not more, is to transition them to a different opioid, either buprenorphine or methadone. Fentanyl is something that might be taken 10 or 12 times a day, is unpredictable. You might be smoking it, you might be injecting it. What we're trying to do is get a person off of the roller coaster of fentanyl use and into feeling normal. And for most people who have opioid use disorder, they find they feel normal on another opioid. Those opioids that they're on are generally taken either once a day or once a month. And they keep a person at a steady state and feeling normal. And with that, getting off of the roller coaster of biology, the impact of that is that they can then begin working on and calming down the psychological and social components of their addiction. And so in that instance, a person then is really in recovery from fentanyl use disorder while they're using treatment medications. Some folks stay on those medications for months and years, others taper off of them. So there's different patterns there.
What caused the change from oxy to fentanyl around 2018?
So the oxy change really happened in 2010 when oxy was reformulated by the manufacturer in OxyContin. So that's really when we saw the big transition in oxycodone and the pharmaceutical products. So there was a big decline in pharmaceutical prescribing overall for opioids, and with that decline, we actually saw a dramatic increase in heroin addiction because we did not prepare for it appropriately and expect to be needing to treat all of those folks. And then fentanyl came on and just accelerated what we were seeing already.
So this next question, I believe, has to do with drug checking. So when fentanyl is found in non-opioid or illicit drugs, is it there by cross-contamination or is it intentionally added?
Well, we certainly know it can be there by cross-contamination. I think we just don't know whether it's intentionally added or not. We don't know. I can make up a few different stories, and there's probably instances where it is, but I think generally we just really don't know that.
Any insight into the form of fentanyl people are using, blues versus powders? Also, in the way people are using clinically, it seems as if people are generally smoking fentanyl rather than injecting, although I have also heard this varies across the country.
Yeah. So great question, and I'm curious what you're seeing in your practice as well. We are definitely seeing a lot more powder. We definitely see a lot of smoking. We are hearing some about people sort of going back to injecting with powder. We're actually just going into the field right now with the statewide syringe service program survey that will really dig into this. So we'll have much richer data on that in just a few months. It's just as you know, it's just things are switching really quickly. And we're kind of going back and forth in terms of which form, what route of ingestion. It's just a really complicated time.
We'll be in the desert.
Yeah. So I think with that, we're at time. I really want to thank everybody. I appreciate the questions. And I realize we just scratched the surface of this. It's really complicated what's going on. And it's more complicated than it was 22 years ago. This was a much simpler presentation back in the day. But I think the complexity really speaks to the complexity of what's happening to people in our community, and also the greater complexity and really robustness that we need to have more comprehensive services for folks. So With that, I'll just say thank you. I appreciate it. Please take a look at our webpage. There's a ton on there, and feel free to follow up with us if you have more questions. So thank you very much.